Hello, friends. A very good evening to all of you. So, please confirm if you can see my screen and if I am audible to you so that we can start this recall session. Waiting for your replies. So, am I audible and is my screen visible? Thank you, Sajid. So, once again, a very good evening to all of you. So, all of you who have appeared for the INI-CET exam, you must be feeling really relieved after appearing for your exams. But after every exam, after obviously we should take a break, but we should also pause down and try to recollect what all questions came and whether we were able to perform to the best of our expectations. It will be a helpful exercise for all of us, for all those who appeared for the exams, as well as for your friends and juniors who might be, planning to appear for the exam in the next session. Okay. So this will be a very short recall session for, the questions that came from pediatrics. And we will start with a disclaimer that the questions discussed here might, differ from what was asked actually in the exams, and these questions are purely based upon the recall provided by you students, right? So we'll try and sort of modify and we'll try to crystallize and come to the exact question and the best possible options that were there, right? So again, this time there were almost 20 odd questions from pediatrics, and the topics asked were again very, very simple, and most of which we have covered in all our, videos, and large number of them have been covered in the rapid revision and the last resort revision sessions also, right? So I hope you have, you pediatrics has been a very scoring subject for you in the INI-CET exam. Yeah. So good evening, Sajad, Prathvi, Dr. Revati, Mayur, Jish, Lokendra, Priya. Okay. So overall, how was the INI-CET exam? I believe it was so mixed feelings, I think, but overall, the impression that I'm getting is that it was not so difficult and a large number of repeats were asked. Especially from pediatrics, I can see so many questions that have been repeated, so many topics that have been repeated, right? And of course, a few new ones always come as a surprise, right? Okay, so let us start straight away with the first question that I have here. So, what we have here is, a 1 day old neonate, so a baby who's just born, presented with scaphoid abdomen, respiratory distress, and mediastinal shift. All of the following can be done except, and I can see already, Sajad, Sai, Priya, Mayur, KK answering, right? So, this typical case scenario suggests a diagnosis of CDH or congenital diaphragmatic hernia. And we know in congenital diaphragmatic hernia, we must avoid bag and mask ventilation. Congenital diaphragmatic hernia is an absolute contraindication for bag and mask ventilation. So if you have a child if a neonate with a known diagnosis, known antenatal diagnosis of CDH, or you're suspecting CDH, based on your clinical presentation like given here, then we must avoid bag and mask ventilation. Oxygen mask can be given. Positive pressure ventilation can be done with a, you can do the endotracheal intubation, and on that tube you can attach the bag. So bag and tube ventilation can be done. That is the form of positive pressure ventilation that can be done in these babies. Endotracheal intubation will be helpful in babies with severe respiratory distress, but bag and mask ventilation is not to be done in these babies. So that is the best answer, right? The next question, again a pretty straightforward question, a direct repeat from previous years. Enzyme deficient in Pompey's disease. So Pompey's disease we know is type 2 glycogen storage disorder. It is one of the muscle glycogenosis, and the enzyme deficient in Pompe disease is alpha 1,4 glucosidase. Very good, Priya. And so, what kind of a name is paracetamol? Nice name, by the way. So, Revati, yes. So, enzyme deficient in Pompe disease is alpha 1,4 glucosidase, or it is also known as, another name for this enzyme is acid maltase, right? So, when this enzyme is deficient, what happens? There is hypotonia, generalized hypotonia. So, skeletal muscle is involved, there is muscle weakness. It is a floppy child with a frog leg kind of posture, head lag is there. Plus, cardiac muscles are also involved. So, there's cardiomyopathy. So, on chest x ray, you can get cardiomegaly and you can also get ECG changes. Why Pompe disease is important for us? Because enzyme replacement therapy is now available for Pompe disease, making it one of the treatable metabolic disorders. Okay, right. The next question, again a simple one. Which of the following is not seen in Down syndrome? So, Down syndrome is a very important topic. Often questions have come from karyotype, screening of Down syndrome, clinical features, and so on. So, this time it was about the clinical features of Down syndrome. Which of the following is not seen? Don't miss the word not, okay? So we know hypothyroidism is definitely associated with Down syndrome. Hearing loss is also associated. These individuals have short stature. But caudal regression syndrome is not one of the typical features of Down syndrome. Caudal regression syndrome is the most specific abnormality that you see in infant of diabetic mother, okay? But not so common in Down syndrome. Rather, you will have atlantoaxial instability or dislocation in children with Down syndrome, okay? Very good. So KK, Arshdeep, Aniket, Mayur, Revati, very good. Now the next question, again, a very straightforward and a simple question, and we've discussed it previously also. At 6 weeks of life, a child developed fever after DPT vaccination. So nowadays we know DPT is given as a part of the pentavalent vaccine. Okay. And now child is 10 weeks due for vaccination. What should be done next? So, developing a fever after DPT is not a contraindication for DPT vaccination, right? So, what will you do? A. Give DPT vaccine. B. Give DT. C. Don't give DPT. D. Don't give any vaccination. So, pretty straightforward question. We know that DPT vaccine or most of the vaccines are going to cause some fever, some local discomfort, redness, swelling, and all that can be there. There are some vaccine specific side effects also, like DPT, the pertussis component especially is notorious to cause, some severe side effects like hypotonic, hyporesponsive episodes, persistent inconsolable cry, seizures can be seen after, DPT vaccination. But, contraindication to the next dose of DPT vaccine are, one is anaphylaxis to the vaccine. Okay, if somebody received DPT vaccine or DPT containing vaccine and had anaphylaxis, the next time you will not give it. Or, if the child had, some serious, has a progressive neurological disorder, then you may avoid DPT vaccination. But otherwise, you will continue to give DPT vaccination. It is not contraindicated as such. Okay, after fever. So give DPT vaccination. Okay. Pentavalent, if pentavalent was there in the options, we will give pentavalent vaccination. What are the components of pentavalent vaccination that is there in the national immunization schedule? We know DPT is there, then hepatitis B and HIB, that is Haemophilus influenzae type B, right? Very good, Priya. Okay. The next question, a child, again a very important topic repeated n number of times. So, important topics remain always important, right? So, a child came to the OPD with, fever for 6 days with strawberry tongue. You can see the strawberry tongue here. Okay, you can see the strawberry tongue, conjunctival congestion. You can see. So, strawberry tongue is there, conjunctival congestion, and peeling of the skin. What should be the ideal treatment? So, here we are dealing with a typical case of, yes, what is the diagnosis here? So, we are dealing with a typical case of Kawasaki disease, right? So, in Kawasaki disease, we know the treatment of choice, if you ask me, is IVIG or intravenous immunoglobulins. Of course, you also use aspirin in the treatment. Plenty of fluids as such is not recommended, but normal fluid intake. You need not restrict fluids also. So, normal fluid intake is to be given, and cephalosporins as such usually are not indicated, right? So, the ideal treatment would be IVIG or intravenous immunoglobulin. Very good. KK, Mayur, Piyush, Vajahat, Sai, KK, right? So IVIG or intravenous immunoglobulins. And a very important complication of Kawasaki disease is coronary artery aneurysm. If you give IVIG timely, then this complication can be avoided. And aspirin is also used. Definitely, you're right, KK. Aspirin is also used. But the ideal treatment or drug of choice, if you ask me, then the best answer would be IVIG. And of course, along with that, aspirin is also used, right? So if one option had IVIG plus aspirin, I would rather go for that option. But if separately they are asked, then we'll prefer IVIG over aspirin. Okay? Right. And aspirin initially high dose followed by low dose, just like you do in rheumatic fever. The next question, a child has features of meningitis. So you have a child who has features of meningitis with the following CSF finding examination. CSF findings, right? So protein of 63, glucose of 20, lymphocytes positive. What is your diagnosis? So, again, this I believe is an incompletely recalled question. So, ideally, the question would have had, some more history, like, the duration of illness. So, whenever, please, if you feel that a question is incomplete, or it is, some other information must be included or modified in it, please let me know. Okay. So, ma'am, when Moro's reflex disappear, which milestone comes? So, Moro's reflex disappears at 5 to 6 months of age. As such, Moro's reflex is not linked to any particular milestone, but asymmetric tonic neck reflex disappears at the same time around 5 to 6 months, and when it disappears, the baby learns to roll over from prone to supine and supine to prone. Right. So, if a child has features of meningitis with the following CSF examination: protein 63, glucose 20, lymphocytes positive, what will you think of? We will not think of bacterial meningitis, because bacterial meningitis you will have neutrophilic predominance, and proteins can be higher and glucose low can be there. Okay. And the cell count also ideally should have been mentioned. The duration of illness should have been mentioned in the question. I believe it might have mentioned, and where probably you forgot to recall. So, yes, definitely protein is almost normal here, but glucose is low and lymphocytes are elevated. So, glucose is low, and ideally, again, you have to compare the CSF glucose with the blood glucose. Okay. So, glucose is low and lymphocytes are low. So, it is consistent with viral meningitis. Tubercular meningitis, the proteins would be elevated. Okay. The proteins would be highly elevated in tubercular meningitis, and of course you get a lymphocytic predominance. So this does not, the given findings are not consistent with tubercular meningitis also. So out of the given options, viral meningitis seems to be the best possible option, right? Okay. So moving on to the next question, again a very very simple and straightforward question. I am sure all of you have marked it correctly. So match the following, right? So autosomal dominant inheritance, which of these has got autosomal dominant inheritance? So, cystic fibrosis, Leber hereditary optic neuropathy, Duchenne muscular dystrophy, myotonic dystrophy. So, myotonic dystrophy shows autosomal dominant inheritance, though it has, a sort of a little bit of this atypical inheritance pattern is also seen. But autosomal recessive, we know it is definitely cystic fibrosis, CFTR gene involved. The most common mutation has been asked previously, delta F508, right? Mitochondrial disorder, we know it is Leber hereditary optic neuropathy, right? And X-linked recessive disorder is Duchenne muscular dystrophy. So that is the best answer to this question. The option which has A4, B1, C2, and D3, right? So very, very straightforward question based on the inheritance pattern of common diseases. So, moving ahead, again, this question we've discussed so many times in the LRR session, also probably, and in rapid revision and the main videos also. Causes of non-immune hydrops vitalis are all except. So we know all of the given conditions are causes of hydrops vitalis. Hydrops vitalis means accumulation of fluid in two or more body compartments of the fetus. So hydrops vitalis can either be immune. Immune hydrops vitalis is either due to RH incompatibility or ABO incompatibility. And rest of all the causes of hydrops vitalis come in the non-immune cause. And there's a long list which we've already discussed, right? So ABO incompatibility, very good, Arshdeep, Sai, Priya. So ABO incompatibility leads to immune hydrops fetalis, not non-immune. While congestive cardiac failure, parvovirus, chromosomal anomalies, all these are causes of non-immune hydrops fetalis, right? So don't forget to read the except in the question, right? Okay. So Prashant is telling this question was not there in the exam. Okay, maybe. So if others can also opine if this question was not there, or if a similar question was there, you can message me or email me. Okay. So the following findings can be seen in. So what you see here is a slap cheek appearance of the rash. So you can see slap cheek appearance of the rash, and it is seen in which disorder? Molluscum contagiosum, parvovirus B19 infection, hand, foot, mouth disease, or Kawasaki disease. Yes. So slap cheek appearance of the rash is seen in which disorder? It is seen in erythema infectiosum. And erythema infectiosum is caused by which organism? Parvovirus B19, right? Okay. So Saurav says no question was there on slap cheek, but it is, these are some of the questions that I've got from the recall of some of the students. So maybe they remembered it incorrectly. So if there are, questions similar to this, so some other rash was there, then please share that picture. You can either share on the chat box, or you can message me on my Instagram or other social media handles, or you can email me. Okay, I'll show you the this email ID in the end, right? So the next question, was there a question like this? A baby boy of 6 months age, last dose of vaccine taken was OPV3, FIPV2, and Rota 3. Birth dose of hepatitis B and BCG was taken. What is the next vaccine scheduled for the child? Was there a question like this? Yes. So MR vaccine, obviously, next vaccine scheduled for this child will be at the completion of 9 months, and we will be giving the MR vaccine and vitamin A. And nowadays, we have also added, so pneumococcal conjugate vaccine booster dose and FIPV third dose is also to be given at 9 months. So you will give, okay. So Garima feels yes, it was there. Ashdeep also, okay. And secondary, what kind of a name is secondary? Okay. So Mayur, Muhammad Hassan, Ashdeep, okay. So, MR vaccine subcutaneously on right arm and vitamin A orally at 9 months. MR vaccine subcutaneously on left arm, vitamin A orally at 9 months. MR vaccine subcutaneously on right arm, vitamin A at 8 months. And left arm, vitamin A orally at 8 months. So, we know at the completion of 9 months, we are going to give the MR vaccine. And remember, BCG vaccine, we give it conventionally in the left arm. So, MR vaccine is given on the right arm. And BCG, the route of administration is intradermal. MR vaccine, the route of administration is subcutaneous. So, MR vaccine subcutaneously on right arm and vitamin A orally at 9 months is the best answer out of the given question. Okay. So, let us just quickly see the site of administration of various vaccines. So, BCG we all know. So, BCG, it is upper arm, left side, and intradermal, right? Hepatitis B, the birth dose is intramuscular anterolateral aspect of the left thigh. OPV we know is oral. Pentavalent vaccine is given. So pentavalent vaccine is given anterolateral aspect of the thigh left side. Okay, pentavalent anterolateral thigh left side. Fractional IPV is given upper arm right upper arm. Rotavirus again oral. Pneumococcal conjugate vaccine is given on the anterolateral aspect of the thigh right side. MR vaccine you can see is given on the arm, upper arm right side. Okay, right? Japanese encephalitis, upper arm left side. So these are some of the routes that have been recommended by the National Immunization Schedule of India, right? Similar question was there. Which of the following injectable vaccines are given on the anterolateral part of the thigh? So we know BCG. Where is BCG given? So BCG we know is given on the left upper arm, not on the thigh. MR vaccine. MR vaccine we already discussed just now. It is given in the right arm. Okay. So not on the anterolateral thigh. JE vaccine. JE vaccine again is given on the arm usually, but pneumococcal conjugate vaccine. So let us go back to our table. You can see the pneumococcal conjugate vaccine is given on the anterolateral side of the thigh right side. Okay. While JE vaccine is given in the upper arm. So pneumococcal conjugate vaccine is the best answer out of the given options. Okay. Right. So Sai is right. Very good. Saurabh feels that there was no question like this. So Saurabh, please help me with the exact question. What was the question regarding the site of vaccination? Okay. Management of decay in a child, what is followed? So there, I could not get the exact options. So was it a case scenario based questions and question, and what exactly were the options? If you can help me. So Garima, you're talking about which question? So DK, stat dose given followed by regular infusion of insulin zero point 0.1 unit per kg with IV fluids. Infusion of regular insulin 0.05 to zero point 0.1 unit per kg per hour after 1 hour of IV fluids. Bolus subcutaneous insulin given. So B is the correct answer. So infusion of regular insulin is given. You can give 0.05 units per kg or 0.2, 0.1 unit per kg per hour. But in the first hour, you have to give IV fluids only, right? So this was a case scenario, Akif says. So if someone can help me with the exact case scenario and the exact options, the third option here I don't have. Bolus subcutaneous insulin is not to be given. So Mohan Raj asks why right and left. So what's the significance? So conventionally, it is taken that way. So that, because most of the parents will not be able to tell you which vaccine was given, so based on at which site it was given and at what age it was given, we can make out whether a particular vaccine has been given to the child or not. So that is the significance. If we know that at birth some vaccine has been given in the left upper arm, we know that the child has received BCG probably. At 9 months, if a child has received some vaccination on the right upper arm, we know that MR vaccine the child has probably received. So that is how, because given the ignorance level and the education level of a majority of the population of our country, most of the times they will not be carrying the immunization card also if they are coming for some other ailment apart from immunization. So that is why they have this particular sites recommended. Conventionally we give those particular vaccines at those sites only, right? I hope you get the reason, Mohan Raj. Okay, so the next, I believe there was a question like this on cystic fibrosis again. So, sweat chloride and pancreatic levels of chloride in cystic fibrosis are. So, we know sweat chloride increases. Sweat chloride is more than 60 milliequivalent per liter in cystic fibrosis. Okay, and that is why you have the salty kiss because of excess sodium chloride in the sweat, right? So, chloride concentration increases in sweat and increases in pancreatic secretion, or in decreases in sweat, decreases in pancreatic secretion, or increases in sweat and decreases in pancreatic secretion, or decreases in sweat, increases in pancreatic secretion. So very confusing kind of options are there, but one thing that we know for sure is sweat chloride level is more than 60 milliequivalent per liter, and there is salty case also because of that in cystic fibrosis. So sweat chloride is definitely going to increase. So it will be either option A and or it will be option C, chloride concentration increases in sweat. Okay, and in pancreas the reverse happens. Okay, so in pancreas, the pancreatic secretion, the pancreatic juice which is secreted, so chloride is not able to go there, so chloride transport is affected. The CFTR chloride gene is a chloride channel is affected, so it decreases in pancreatic secretion. So chloride concentration increases in sweat but decreases in pancreatic secretion is the best answer. Wow, very good. So Priya, Secondary, Arshdeep, Mayur have answered it correctly. So proud of you guys. Okay. So again, this is a pretty simple, straightforward question based on genetics again. So trisomy 13, 18, 21, sickle cell anemia. So we all know trisomy 13 is what? Patau syndrome. 18 is Edward, E for E. Trisomy 21 is C, that is Down syndrome, and sickle cell anemia 4A, glutamine to valine replacement at the sixth position of the beta globin gene. So the best answer here is the one which has 1D, 2B, 3C, and 4A. Right? Very good, Revati. So A is the best answer for this question. Right? So very, very simple questions from pediatrics. Again, this is a direct repeat. If this question came again, this is a previous repeat from the INI-CET. So newly approved drug for Rett syndrome, we all know it is trofinetide. Okay, which enhances or stimulates synaptic maturation. Okay, so trofinetide is the newly FDA approved drug for Rett syndrome. Right? So Garima says trisomy was not there, but there was one question about features seen in Down syndrome. Okay, Garima, if you can help me with the exact question, you can, whenever you are able to recollect the question, please email it to me or you can message it to me directly. Okay. So Akif feels this question about Rett syndrome drug was not there in the paper. So, I don't remember, but some student has shared this question with me. So, if anyone else can also opine whether this question was there or a similar question was there, please message it to me directly. Another question that I got from the recall: child with 3 days history of watery diarrhea, vomiting, and altered sensorium presented to pediatric OPD. All of the following all of the following can be included in differential diagnosis except. So we all know if a child with diarrhea is having altered sensorium, we have to think of what all things we will think of. So except is there in the question. Please don't forget to notice this. Okay. So hyponatremia. Hyponatremia can be a possibility because electrolyte imbalances can give rise to it. Severe dehydration remains a possibility. Yes. HUS we will not think here because the child is not having thrombocytopenia or bleeding manifestations, or the child is not having severe anemia or renal shutdown. Cerebral vein occlusion remains a possibility, right? So HUS is the best answer out of the given options. So it is possible that some students have mixed up some questions and maybe they are recollecting the GT questions and the NICT questions. So there is definitely a possibility because these are all recall based questions from so many students. So please feel free to message me or email me the exact questions that you remember so that we can come up with a more refined version of the questions, right? So the another question that I got is a 9-month child presents with fever and cough. So was there a question like this? A 9-month child presents with fever and cough. On examination, no chest retractions, respiratory rate 46 per minute. What will be your management? Okay, so Akif, so Abhishek says ये question नहीं आया and Akif says because of bloody diarrhea rule out HUS. I still remember this question. So I'm sure it is very difficult to recollect all the questions. So many questions were there. So definitely it is difficult on your part to recollect the questions correctly. But that's okay, I think. But important topics definitely remain important. So that's okay if you feel that if any of the questions that we have missed or any question needs modification or some question was there or not there, please feel free to message me the same, right? So I'll help you with the discussion and with the answer as well. So the a question was there like this. So if someone can help me with the exact question. So a 9-month child presents with fever and cough. On examination, no chest retractions, respiratory rate 46 per minute, management. So we know whether fast breathing is there or not. First, we have to see that. So less than 2 months, we call it fast breathing if it is more than 60 per minute respiratory rate. 2 to 12 months, we call it fast breathing if respiratory rate is more than 50 per minute. And 1 to 5 years, we know we call it fast breathing if the respiratory rate is more than 40 per minute, right? So here the child is 9 month old. So we will call it fast breathing if the respiratory rate is more than 50 per minute. But you can see the respiratory rate is only 46 per minute. So it is not fast breathing. So no fast breathing is there, no chest indrawing is there, and any general danger sign is not mentioned here. So this child has no pneumonia and it is cough and cold only. So no pneumonia, cough and cold only is the answer. So symptomatic treatment is to be done and the child is to be sent home with warning signs, right? So danger signs you have to explain the child when you send the child home. IV antibiotics and hospitalization is not required. There's no terminology called mild pneumonia in the MNCI guidelines, and here oral antibiotics are not required. Urgent referral is not required. So we all know if there is no fast breathing, no chest indrawing, no general danger sign, it is no pneumonia, cough and cold only. If there is fast breathing and or chest indrawing but no general danger sign, then it is pneumonia and you have to prescribe oral antibiotics with which the child can take at home, oral antibiotics for 5 days, and you call the child after 2 days to reassess. While if any general danger sign is present, irrespective of whether fast breathing or chest indrawing is present or not, then you categorize the child as severe pneumonia or very severe disease. You give first dose of parenteral antibiotics and Repfor. So very important topic. Again, we have discussed n number of times in our LRR session also we've discussed about it. So IMNCI categorization and management of pneumonia remains very important, right? So these were some of the questions that I got from the recall of the students. So if there are any other questions, please feel free to message me or you can email it to me at my email ID, right? So if there are any other questions, I'll be happy to take them as well. So was there any question on developmental milestones? So I believe there was some question on developmental milestones. If someone remembers, please message it to me. Any other questions that you remember from any chapter in pediatrics? So please feel free to message. So general pediatrics or systemic pediatrics or neonatology, if there are any questions that we missed upon in this session, please feel free to reach out to me for the answer, right? So no, Mohan Raj, as such, there is no score for a child with respiratory distress that we use. In neonates, we use Silverman score, Downey score, but usually in older children, we're not using as such a score like that. So Akif says, तेज एक बार slides दिखा दे. Okay, before we end this session, तेज I'll show. So then it is a possibility that some of these questions were not there in the actual exam and some students might have mixed it up with some GTs or the previous year questions. That's a completely okay. Just important topics remain important, and if there are some questions that we've missed upon, please message it to me and I'll definitely get back to you with the answers, right? So there was this question on the case scenario of CDH, and we all know bag and mask ventilation is contraindicated. Arshdeep says no question on milestones. One of the students messaged that there was a question on developmental milestones. Okay. So, enzyme deficient in Pompe disease, we know alpha 1 4 glucosidase or acid maltase, not seen in Down syndrome, caudal regression syndrome, vaccination, fever, DPT. After DPT, you still give DPT vaccination, not contraindicated. Kawasaki disease, we know drug of choice is IVIG. Then, if you are getting a case scenario of meningitis and the glucose is low, lymphocytes are there, protein is normal, think of viral meningitis. Match the following based on genetics. Very, very easy. We need to know the mode of inheritance of the common disorders. Non-immune hydrops, we know. Immune hydrops is ABO incompatibility or RH incompatibility. Rest all are non-immune hydrops. This slab cheek appearance is erythema infectiosum parvovirus. Then we saw a question on immunization, site-related question. So we already discussed the various sites of different vaccines. So MR vaccine is to be given subcutaneously on the right arm at 9 months. Okay. So remember that. So we already discussed the various sites of various vaccines. Anterolateral part of the thigh, we give the pneumococcal conjugate vaccine. Then decay management is being asked nowadays. So first hour, you'll give only fluid. Following that, regular insulin infusion is to be given at 0.05 to zero point 0.1 units per kg per hour. Cystic fibrosis, again another hot topic. So sweat chloride concentration increases while the chloride concentration decreases in pancreatic secretion. Again another question on simple genetics mechanisms. Very, very, easy. What abnormality is found in which disorder? Newly approved drug for Rett syndrome, trofinetide. And this watery diarrhea question with a child with altered sensorium, you'll think of electrolyte imbalances, severe dehydration, cerebral sinus venous thrombosis. And then this case scenario on IMNCI, we all know no fast breathing, no chest indrawing, no general danger sign. It is no pneumonia, symptomatic treatment, send home with warning signs. So that's all from my side. Okay. So some of the questions were not there, but think that's absolutely okay. Please don't fret over that. It's fine. But do if some questions we have missed upon, please feel free to message it to me. I'll get back with the answers. And important topics definitely will remain always important. So just relax. Give yourself a couple of days. INI result comes out quickly only. We all know that. And I'm sure most of you who have worked really hard with that goal in your mind, and very, very, you've remained very, very focused, you're going to crack it. Some of you might not be able to make it also, but that's also completely okay. It's okay. Give yourself a break if you're not able to make it this time. But definitely be sure that there are good things in store for you as well. Keep working hard, and we are always there to support you. So, all the very best, friends, for your results, for the upcoming exams, and for a bright future ahead. So, thank you so much. Thank you.